All right, I think we'll go ahead and get started. Welcome, everyone. Good morning. I'm Dr. Elizabeth Lageson, and I'm the incoming director for the UCLA Tarjan Center, which is a university center for excellence in developmental disabilities. And on behalf of the Tarjan Center faculty and staff and our co-sponsors, the UCLA Intellectual and Developmental Disabilities Center and the UCLA Center for Autism Research and Treatment, it's my pleasure to welcome you to our monthly lecture series and also to welcome our distinguished panelists. Now, before we get started, just a couple of housekeeping items. We will be hosting a 5 to 10 minute Q&A at the end of the panel. So please use the Q&A feature, not the chat feature, but the Q&A feature on your Zoom toolbar to share your questions and comments. Also, at the end of the lecture, we'll be sharing an evaluation link. And so we encourage you to complete this brief evaluation, but also include any topics that you might like to hear for our lecture series next academic year. All right, so without further ado, it's my pleasure to introduce our speakers today. To begin with, I'm happy to introduce Dr. Camille Wilson, who is a pediatric neuropsychologist at Nationwide Children's Hospital. She completed her doctorate in human services psychology at the University of Maryland in Baltimore County, and her pre- and postdoctoral training at Nationwide Children's Hospital. She specializes in neuropsychological evaluations for children with chronic medical conditions. She's very passionate about expanding access to psychological services to medical populations, as well as preparation for transition to adulthood and clinical training for future neuropsychologists. Our second panelist is Sapna Shetty, who is a licensed couples and family therapist and marriage and family therapy supervisor at the Child Development Center at Nationwide Children's Hospital. Sapna's work includes diagnostic assessment for children presenting with developmental delays and/or autism spectrum disorder, along with family therapy for the entire family system. She is also the co-director of the Couples and Family Therapy Internship Program and a steering committee member of the Diversity and Inclusion Committee at Nationwide Children's Hospital. And our third panelist today is our very own director of training at the Tarjan Center, Dr. Jasper Estebia. I'm sure you know her well. She is a licensed clinical psychologist in the Developmental Behavioral Pediatrics Program at the UCLA Mattel Children's Hospital. She completed her doctorate in clinical psychology at Louisiana State University and her pre- and postdoctoral training jointly at the UCLA Semel Institute for Neuroscience and Human Behavior and the UCLA Department of Psychology. So Dr. Jasper Estebia's work focuses on providing direct clinical services to families, improving clinical training, and expanding access to evidence-based interventions in the community. So today, our distinguished panel will be presenting, I'm sure, what is promising to be a very interesting discussion entitled "Using Silence to Hear the Voices of the AAPI Community in Autism Diagnosis and Treatment." So please join me in giving a warm virtual welcome to our panelists.
Thank you, Dr. Lageson, for that lovely introduction. Let me go ahead and share my screen so that way we can get started with our talk here. All right, okay. And so it is my pleasure to be here with my co-authors to present on today's talk, Using Silence to Hear the Voices of the AAPI Community in Autism Diagnosis and Treatment. Before we get started, though, we would like to take a moment to acknowledge the events that happened in Buffalo this weekend. Our hearts go out to the families affected and to the Black community. And may this highlight to all of us the importance of continuing to do the work and supporting each other in these times. All right, okay, here are my wonderful co-authors. In terms of our learning objectives for today, firstly, we want to understand some of the cultural complexities of working with AAPI families in clinical settings. We want to describe some cultural considerations for the IDD and ASD assessment process. And lastly, describe cultural considerations for providing treatment recommendations. In addition to our Q&A, which will be at the end of our talk, we'd also like to ask our attendees to think of your own experiences of working with AAPI families, or maybe your own experience of going through this process yourself. Use that as a point of reflection throughout the talk. And we actually have one point in the middle of our talk where we'll be asking some feedback from the audience in the chat feature. All right, so to get started, We want to begin with the Chinese proverbs, silence is golden. So this proverb reminds us that the discipline of silence can actually be a source of great strength and wisdom. We draw a distinction that silence is not invisibility. Silence may be misunderstood to create the cover of invisibility that actually leaves minoritized populations feeling unseen and unheard. We view silence rather as a way to create an opening and a space to allow us to hear the voices that may have felt invisible and to hear what's not being said. Silence can be used instead to strengthen connections, to improve the assessment process, as well as avoid potential pitfalls that can hide the true needs of the Asian American, Native Hawaiian, and Pacific Islander community. All right, and with that, I will pass things off to Camille to get us started.
Thank you, Jasper. And what I'm going to do is just to start to talk about our AAPI community and more generally, and then we'll be working in to think about some of the cultural complexities that we may encounter in our work with this subgroup. So going to the next slide, thank you. So who makes up the AAPI community? What we know based on the most recent US Census data is that the 6% of the US population identify as Asian. And this is a really large heterogeneous group that is comprised of 50 ethnic groups, over 100 languages. The infographic to the right shows us that the largest AAPI subgroups include Chinese, Asian Indian, Filipino, Vietnamese, and Korean. But if you look at that other box that's highlighted there, you can see that there are many other AAPI subgroups that include Central Asia, South Asia, Southeast Asia, as well as our native Hawaiians and Pacific Islanders. The states in the US that have the highest concentration of AAPI residents include California, New York, Texas, New Jersey, Illinois, and Hawaii. And what we know is that almost 3/4 of our AAPI community speak a language other than English, with a little over a third who have limited English proficiency. Go to the next slide. So more than a quarter of our AAPI individuals live within multi-generational homes, and over almost 2/3 are born outside of the US. When you look to the right at that infographic there, what we see is that our AAPI members who are born here in the US are actually much younger than those who were born overseas. And actually almost 2/3 of them are Gen Z or younger. So we're looking at a very young age group of AAPI members that are within the younger generation. If you just slide over to the left there and look at that infographic, what we see is a projected trends of growth, population growth. And what we see is that by 2055, there's actually estimates that the AAPI community will outnumber and outpace other ethnic minority groups, racial and ethnic minority groups. If we go to the next slide. So as we think about the AAPI community, historically, the AAPI moniker was created to help galvanize the Asian minority groups into a larger voice. And the AAPI community has grown to be that more prominent voice to help advocate for the needs of Asian Americans living in the United States. But the downside of that AAPI label is that it can hide the heterogeneity within the community. So I think these infographics help illustrate that for us. For example, when we look at income and educational achievement, you can see the data on the left side of each of those infographics illustrates the national trends that are considered for the AAPI community compared to the national average. The right side of those figures shows how those numbers break down when you consider individual subgroups within the AAPI community. And you can see that there starts to be some separation in terms of income, educational achievement, as you start to look more closely at South Asian and Southeast Asian subgroups. Now the slide to the right deals with poverty rates, and we do see that poverty rates do occur at higher rates among the AAPI community compared to white counterparts, and notably the Hmong people experience a rate of poverty that is twice that of white Americans. Next slide. So we wanted to talk a little bit about the AAPI in California for those that may be based out of the West Coast. And what we see is that the AAPI community, like what we see at the national level, is part of the fastest growing minority population in the state of California. The counties that have the highest AAPI populations include LA, Santa Clara, Orange County. What we also see is that there is a higher rate of lack of health insurance. So almost 10% of individuals who identify as AAPI do not have health insurance, and 12% live in poverty. Go to the next slide. And as we start to look a little deeper in at our AAPI community within the educational system in California, we see that out of the 6 million students in California, 12% of these students identify as part of the AAPI community. And even within that 12%, of the 12 most commonly spoken languages in the California school system, what we see is that 5 of those top 12 are represented within our AAPI community. Now, the California School Board Association published a paper in 2019 that a really telling statistic that AAPI students are identified at a much lower rate than any other ethnic or racial group in California. So if 11% are identified with special needs, we see only 6% of the AAPI community making up this group. So as we think about the AAPI community and mental health as a whole, I think this infographic just really nicely illustrates that although the AAPI subgroup may make up a small percentage of the US population, and of that small subgroup, only 15% are reporting a mental health concern. When you put that into actual numbers, you're looking at almost 3 million people who have experienced a mental health concern in the past year. We go to the next slide. What the research has taught us is that the AAPI community has low help-seeking rates. So in fact, they're 3 times less likely to seek mental health help compared to other Americans. Less than a quarter of AAPI adults received mental health treatment in 2019. Some of the reasons for that were shame and stigma, so not wanting other people to find out, concerns about confidentiality, or fear of negative opinions of others who might learn about their diagnosis. We've learned in research that suicide is the leading cause of death for AAPI youth that are ages between 15 to 24, with Asian American women at particular vulnerability for this statistic. We also know that many of our refugees coming into the US are coming with high rates of PTSD, particularly within our Southeast Asian refugee population. Now, if we drill down and look a little more specifically at our developmental disabilities, we see multiple studies have informed us that minority populations may be at higher risk of underdiagnosis or later diagnosis of autism spectrum disorders. We see the highest disparities seen with our Black and Latinx families, and a lot of important work is being done to help reduce those disparities within this subpopulation. But you know, the 3 of us would respectfully put forward that we must not forget our AAPI families as well, because they are also falling under this under-identified or later diagnosis of ASD as well. And for some of the reasons that have been explored through some qualitative studies of why there may be underdiagnosis or concealment, as I mentioned, there is a large stigma and shame associated with mental health diagnoses, including autism. And so even some studies showing that in Korea, clinicians may designate a different diagnosis instead of autism in order to help families avoid that social judgment or rejection. Kang Yi and colleagues in 2018 published some qualitative studies of families who shared that they had individuals in their families shunned or even rejected for suitability for marriage because of a loved one's autism diagnosis. Now, Klebels and colleagues in 2020 published a study looking at the Autism Treatment Network in terms of behavioral challenges, and what they found was that there were no racial or ethnic differences in behavioral challenges, conduct problems, or sleep disturbances among children diagnosed with autism in this network. What they found is that white children were more likely to receive psychiatric medications to treat these concerns. And they also noted that AAPI children had the lowest rates of medication use across all of these areas compared to their non-Hispanic white, Latinx, Black, and multiracial groups. Now, we don't exactly know why that is, but we know that there is that disparity of care. And I think that really calls us as a field to investigate this further to better understand what are some driving factors that could be creating this discrepancy in care. So what we wanted to do at this point was to open things up to you all in the chat. So if you could put into the Q&A, what are some barriers that you have encountered in your work with AAPI patients and families as you have been doing your clinical assessments or work with them? Tell us about some of the barriers that you've seen. And we'll probably open things up if you guys just want to put them into the chat, that would be great.
I'm seeing transportation is in the chat right now. It's certainly a barrier to care.
Mm-hmm.
Another attendee is saying concerns for social judgment from others. And another audience member is saying failure to account for the critical importance of including grandparents, so the multi-generational aspects, and including all of the other family members into treatment. And then another attendee is saying accessible language materials.
Yeah, and I see another put into the chat, ability not to communicate, maybe not being able to speak English. So definitely a barrier that can create challenges.
Okay, and then let's take a few more. So I'm seeing mental health social workers. So the number one is minimization of degree of need and shame with that help seeking, as well as the values of the DD system of independence, whereas person-centered planning may not match the values of the family in that community. And then the last one that I'm seeing here is failure of service providers to refer out if they don't have the language and cultural competence.
Absolutely. Yeah, thank you all for bringing those thoughts to the chat. I think those are all very much barriers to care. And we'll talk about some of these, through our presentation. And hopefully we can engage around some of these barriers towards the end of our conversation as well, and thinking about what are some creative ways that we could work with our AAPI families. I saw in the chat that there was a question about what does AAPI stand for? And so that's Asian American Pacific Islander, but that has also expanded to include like Asian American, Native Hawaiian, and Pacific Islanders. So it's really kind of a term that's evolved over time, and with some shifting in terms of preferences and so on. So let's go on to our next slide, and hopefully we can touch on some of the barriers that you all have put into the chat. So, I think one barrier that we may face is translation of the concept of autism across cultures. Actually, Sapna shared a really poignant experience that she had in working with an interpreter, a Somali interpreter here in Ohio, who paused the feedback session to say, you know what, Somali doesn't have a great word for autism, right? And so what we've seen from that personal interview, as well as through other literature, is that in Somali, autism is often translated as Western disease or crazy. And so you can imagine, as a family member sitting and listening to a feedback session as you're diagnosing autism, that they're hearing the interpreter tell them that, your child is being diagnosed as crazy or having a Western disease. And so it's so important to pause and to ask, what does the family understand in the conversation of what is the meaning that the vocabulary that we're using? Even in the Maori language, takiwetanga means in his or her own time and space, right? And so that may carry a very specific definition or connotation. And so being able to talk with families and really making sure that you are coming from a shared place of understanding is so important. So not only understanding what does autism mean in terms of the specific behaviors and the impacts that we're seeing in a child's ability to function in their setting, but also to really explore with the family what their understanding of the autism diagnosis, where it came from, right? Because I think there are some of our families who may conclude that there are factors within the child's environment, the social setting, or maybe even family influences that contributed to autism. You know, there are some families that we've worked with that believed the lack of exposure to their home culture or community may have contributed to their child's diagnosis. And that can help compound some of the shame and guilt that a parent may feel in how they failed in their role as a parent to provide for their child. Other barriers to care can include families feeling unheard or invisible. So some of the qualitative research by Stammer and colleagues had worked with minority families more generally, but I think they apply here. So families have talked about feeling unheard or invisible because of lack of access to interpreters in their preferred language. So very much like what was referenced in the chat earlier. And then families have also felt dismissed or not taken seriously when they have brought concerns maybe to a care provider. So, you know, maybe a parent went to a provider and said, you know, I'm concerned because my child seems delayed in their language. And then to have the provider say, oh, that's okay. You live in a multiple language home. You know, that's why your child is delayed, without taking that time to hear, what are you seeing? What is not matching in terms of your culture's expectations? And so then missing that opportunity for that shared conversation. Another area where families have felt lost in the process of autism diagnosis or evaluation and treatment is just that lack of familiarity with the autism service system and how to access different pathways of care. Just feeling like that there's a lot of resources that may be out there, but they're not sure how to access them or where to find them. We could go to the next slide. And finally, another barrier to care that's been identified through the literature is just uncertainties with the advocacy process. So as we talk with our families, we often want to empower them to take on that advocate role. But I think it's really important for us to remember that that advocacy role may feel at odds with an individual's cultural values of, you know, wanting to save face or not appear disrespectful. Other individuals may feel vulnerable and not confident to speak out because of their immigration status and fear of deportation. Um, Other individuals may feel uncomfortable taking on this advocacy role in a language that they are not comfortable speaking. It's not their primary language. And then speaking of language and vocabulary, sometimes that lack of familiarity with the vocabulary around special education services can feel overwhelming for families who are not familiar with the education system here in the US and don't know what are the things to ask for or ways to frame concerns so that schools, you know, act on that next step. So I'm going to transition things over to my colleague Sapna, who's going to talk about some of the community takeaways for our AAPI community.
Hello, everyone. Thank you for joining us today. So as we look at AAPI community takeaways, it's really important to remember that the AAPI community is not a monolith. The community consists of more than 50 ethnic groups. There are over 2,000 languages and dialects spoken across the continent. And then looking at Asia broadly speaking, it's a home to many different religions, faiths, cultures, and languages. With different cultures and histories in the US, the diversity of AAPI heritage and experience is truly too vast to simplify under one simple label. So we'd also like to highlight the danger of the model myth minority. So the myth is a stereotype that depicts AAPI individuals as well-adjusted, achieving socioeconomic success through strong work ethic, conforming to social norms, and excelling academically. Although this may sound positive, it can actually create social pressures to conform to societal expectations, which can then lead to hesitation and help-seeking behaviors in the AAPI community. I'll move on to our next slide. So as we discuss the vastness and diversity within the AAPI community, we also would like to provide a reminder that's really important to look at culture broadly. So within each family's cultural identity are social location factors that's unique to each family system. It's important to explore the family's social location and barriers that might be wrapped up around them. So I've highlighted some examples here for this family, such as socioeconomic status, English proficiency, primary language, immigration status, and political climate, just to name a few. And I'll move on to our next slide. So as we consider the individual social location, it's really important to also consider how we enter the space when we work with a patient and their families. Our own experiences within the broader context create our own biases and perspectives. This graphic and adaptation of the 2019 AAPI Multicultural Guidelines captures how our families interface within these layers and how we might come into contact with people whose experiences may be very similar or very different from our own. So the questions to the right remind us of how individual social location may impact their engagement during the assessment process. So being mindful of our own perspective helps us to make sure we enter into the assessment process with an open mind. And then some of the questions that we've highlighted here are what may be historical factors that may impact the individual family or community? What are the power and privilege dynamics? As well as what are the different types of identity that an individual may identify with? So here we're looking at the intersectionality that might come about when we're looking at social location factors. We'll move on to our next slide. So here I'd like to share a term that's resonated with my colleagues and I, cultural compatibility, which is a synergistic relationship between cultural competence and cultural humility. So competence is the belief that the greater the knowledge about a specific culture, the greater the competence when working with people of that culture. Whereas when we're looking at humility, it places a greater emphasis on a lifelong commitment. It encourages nurturing of self-evaluation and critique. It's also having the sense that one's own knowledge is limited as to truly what another one's culture is. And then examples of how this might look like in practice. When looking at parenting styles, it's important to make room for families' cultural differences in parenting, which can mean that family roles may be culturally different than what we might assume them to be. There can also be cultural differences in how and when self-help skills are developed and expected, such as differences in independent feeding, sleeping, and toilet training. And then being cautious of what technical terms may mean and taking the time in translating these terms. Also, rather than assuming that the family can read English or can read at all, we want to be cautious of providing supports when there might be literacy concerns. And I'll move on to our next slide. So now let's jump into cultural considerations in clinical settings. So practicing family-centered care, allowing for longer intake appointments as participation of multiple family members or use of interpreter with non-English speaking families can increase time. It's also important to have an interpreter even if one parent is fluent in English. So we want to make sure that the entire family system is receiving the same information and that we're not putting the responsibility on one family member to interpret it for the rest of the family system. And then also taking a learner stance by practicing cultural compatibility. So before going into the session, gaining an understanding on the family's background, but also being open and humble, learning from the family as well of what their culture means to them. Move on to our next slide. So here we're going to look at examples and take questions to incorporate cultural compatibility. And I will not read through all of them, but let's look at some of them together. So how long has your family been living in the USA? What are the languages used at home? How would you identify your culture, religion, and race in your own words? What do family roles look like within your family system? And then has anything prevented you from getting the help that you need? And we can move on to our next slide. So here we're going to introduce a case study. Our hope is for you to be able to use this family story to reflect on the content that we are sharing. So I'm going to share a case study on Amir and his family. So Amir is a 5-year-old Nepalese male who presented with a speech delay. He lives with his parents, 2 older sisters, 10 and 12, and his paternal grandparents. Amir and his family moved here as refugees from Bhutan 3 years ago. Primary language for his parents and grandparents is Nepali. They are not fluent in English. Amir's older sibling communicates in both Nepali and English at home. Amir attends a special needs preschool. However, his family is unaware of what services he is receiving. They have not had any communication with the school. Amir is not receiving any services outside of the school system. At arrival, his family requests for reassurance that their appointment will be covered through their health benefits. Amir and family are accompanied by family friend Arya, who assisted with transportation. Although an interpreter is present, Arya interprets for the family with some support from the interpreter. Family reports primary concerns of a speech delay. Amir has under 10 words in his vocabulary that he uses spontaneously and with function. However, he is often observed echoing others. His expressed words are in English. They report that he does not respond to directions in English or Nepali. His family is confused and unsure of the purpose of this appointment. They request assistance in teaching Amir how to use his words. Amir's family shared a report that was provided by the school. Unable to read English, the family is unaware of what the documents contain. The paperwork confirms that Amir has an IEP under an educational diagnosis of autism. His school identifies concerns with speech, observation of hand flapping, and walking on his tiptoes, along with isolating himself from his peers. His family's primary focus is on speech and requests help in language development. His school is requesting a formal assessment for diagnostic clarification. Clinicians consider possible paths in navigating appointments with this family. So we would like for you to think about Amir and his family as we move through today's content and discussion. So here we'd like to introduce Daryl Fuji's Ecolectic framework. The framework outlines cultural factors that can impact neuropsychological assessments when working with culturally diverse individuals, recognizing how cognitive or autism assessments carries its own biases and assumptions. He reminds us that we need to maintain an ethno-relative perspective, one that allows for cultural relativism or the ability to see our own culture in the context of other cultures. The opposite of this would be an ethnocentric perspective, where an individual may use their own culture as a benchmark by which they measure other cultures. So his framework highlights ways for clinicians to develop strategies to accurately gather information, provide a context to interpret data, and create culturally relevant and sensitive recommendations. The framework highlights education, culture and acculturation, language spoken and English proficiency, economic issues, communication style, testing situation, intelligence concept, and context of immigration. And move on to our next slide. So here we'd like to take the opportunity to use the Ecolectic framework when we look into intake considerations for Amir's family. So Amir's family seems to be really confused about the appointment. Rather than moving directly into intake questions, it's really important for us to meet Amir's family where they're at, assist them in understanding what led to the referral and what the presenting concerns are. We also want to make sure to provide space for the family to express their own concerns. Helping the family better understand the purpose of the appointment may help them feel more comfortable with the assessment process. It's also really important to dedicate time to learn about the family's culture while simultaneously exhibiting humility and acknowledging that the learning also includes understanding what the culture means to that family. And when we do that, we're practicing cultural compatibility. So for Amir's family, it would be a benefit to learn the history surrounding the refugee community of Nepal prior to the appointment, but also dedicating time and understanding the culture from the family themselves. And then questions to think about during this span of the intake is, did the family live in a refugee camp? What exposures did he have to early education opportunities, as well as his exposure to peer interactions? It can also be helpful to consult with a cultural expert to better understand the historical context leading to the arrival to the US. Family is multilingual, with Nepali spoken by the older family members. Language exposure may impact what type of test we decide to use with Amir. Also clarifying with the interpreter how words are being communicated to Amir's family, as Camille had mentioned earlier. It would be crucial to identify how autism is being described to the family to avoid miscommunication. And then when we're considering social location factors, financial concerns seem to be relevant for family, as they were worried about insurance coverage, and they also rely on community members for transportation. So this could impact the ability to attend follow-up or treatment appointments. And then knowing multiple generations attended the appointment, it would be important to better understand the family's hierarchy. So by doing this, we're identifying family roles. So questions we would want to think about here could be, in the family's culture, who are the decision makers? Who can offer insight into Amir's day-to-day social behaviors in the home? And then finally, reassuring family that these are standard intake questions and that everything we discuss here is confidential. With the Nate Poly community being pretty tight-knit and a smaller community, there might be ways of information being shared with other members in the community as well. And now we're going to move on to assessment process with Jasper.
Thank you, Sapna. All right, so jumping into our assessment process, first we know that our current understanding of autism is largely based on Western high-income countries, and our diagnostic instruments are culturally and contextually biased. So when we're creating that assessment battery, we want to firstly utilize our established best practices and also be aware of the standardization samples and norms. So the norms of our diagnostic instruments are based on samples that are about 70 to 80% white. So it's important to take note of this, since this is going to be our benchmark for comparison when we're assessing this child. This also emphasizes the need to integrate data from multiple sources as well as informants. So if there's a multi-generational home, other community members that are involved, the school district, those are all going to be valuable sources of information for us. And taking all together, utilizing our own clinical judgment to see how all of those pieces fit together and create our case conceptualization. We also want to make sure that we're acknowledging any potential cultural differences, values, and expectations. So throughout the course of our intake process, making note of all of those interpretations as well. When we are jumping into our ASD assessment and behavioral observations, we know that the broad domains of autism are found globally, but there are differences in how symptoms may manifest, as well as what those specific behavioral exemplars are that we're looking for. In terms of those social communication and interaction skills, though, they do tend to be more heavily culturally influenced. So in AAPI communities, reduced eye contact may actually be because of the need to show deference to elders and adults that are in the community, rather than any impairments in integrating those verbal and nonverbal communicative behaviors. Social imitation in AAPI cultures may also be considered rude. And so that might be why a child is not demonstrating any of those behaviors in the assessment setting. Speech, as we know, may also be impacted by what languages the child is exposed to. And then lastly, when we're assessing for play skills, we do know that imaginative play is also culturally influenced. And so all of these components are important to make note of when we're assessing for those social communication and interaction skills. For those restricted and repetitive behaviors, though, they do tend to be less culturally bound, but right now there's limited research on potential ethnic differences, if there are any. One thing that's important for us as clinicians to know is that Asian families do tend to describe RRBs as more so disruptive behaviors rather than as any stereotypical behaviors. And so that might be a way to discuss these behaviors if they're present in that child. When we're jumping into the developmental and adaptive assessments, we do know that across the globe and cultures, within the first 3 years of life, most developmental milestones are met at similar ages. The one exception is with self-help skills. So as we've discussed, those adaptive skills and self-help and self-care, those are achieved at very different stages depending on what culture. So here it's important for us to note that lack of opportunity and opportunities for learning does not mean that that child is delayed, right? So that does not mean that this is an absence of a skill just because there is a lack of opportunity. So when you're doing a Vineland or an adaptive measure, if there are a lot of zeros, you want to further probe with the family to see if this is truly a skill that is absent in that child, or if there haven't been opportunities for learning, or if it's not a value for that family. So there we're going to note any cultural adaptations and interpretations in the report. For Asian cultures, some examples of differences in adaptive behaviors are things like co-sleeping, which is common in Asian families, and things like questions like feeding self with fork. That might not be applicable to certain cultures that use their hands or chopsticks to eat. And then communication skills, asking questions about use of articles or irregular plurals in their language might not be applicable, right? In different languages, those types of skills might not apply. So going back to Amir for assessment considerations, when we're creating that assessment battery, again, we're going to utilize our best practices with direct and indirect measures, but we're going to make note of any adaptations or interpretations. So for example, in our ASD assessment, one of the presses, a birthday party, might not be relevant for Amir, right? He might not have had any opportunities or any exposure to a birthday party. It's also important for us to note that his family does not note his lack of social engagement as a delay. As we've discussed previously, many Asian families might note a lack of skill or a delay as a lack of exposure rather than as any challenges that the child's experiencing. So here we want to use that as a point of discussion for the feedback and state why we're seeing this as a difficulty for the child. For adaptive behaviors for Amir, he's fed by his family, and that's what's expected for him as a young child, to be fed by the adults and by his siblings. And so here again, that lack of opportunity and that it's not expected for him does not mean that this is a deficit. So we're going to ask the family what they're not seeing Amir do that they would expect, and that helps us identify where those discrepancies are and what is truly an area of need for him. When we're doing our case conceptualization and interpreting all of these results, again, we want to know any cultural differences and adaptations that we might have needed to make to the measures. And when writing up the report, de-emphasize the scores themselves, right? Because those comparisons are two different sample that might not be applicable for our child, and interpret through that cultural lens. So going back to Fuji's eclectic model, some things that are relevant to him are his exposure to learning opportunities, any cultural differences and expectations for behaviors, as well as what the languages that are used in the home. Here, we want to really emphasize that our assessment measures are tools, right? They give us data to incorporate together and integrate to inform our conceptualization. But we really want to utilize all of those points of information to understand what the areas of need are and how we can continue to support Amir's development. Okay, so passing things back to Camille to discuss some of our considerations for treatment recommendations.
Thank you, Jasper. So you've gone through the assessment process. You've done a careful interview that has considered some of the context and the social location of the individual and family. You've done a careful assessment, contextualizing all those factors that Jasper just talked about. And now we're going to lead into consideration of treatment recommendations. So again, some of the qualitative research out there has really taken a look at what are some cultural considerations to design tailored recommendations that are culturally sensitive and responsive to our minority communities. And so we sort of use the guidelines set up by Sakai and colleagues to kind of think about this. So opportunities to enhance clinical care. So similarly at the intake level, where we thought about having maybe a longer session, maybe thinking beyond that traditional feedback session, maybe viewing feedback as a process. It might be something that unfolds over multiple sessions if that's something that your institution can allow. Maybe it's tailoring how you present treatment recommendations to share with the family. You might not start with autism diagnosis. You might want to start where their concerns were and talking about the speech delay and wondering, you know, at least with Amir, how to best meet his needs so that he can begin to grow and develop in ways that his family is expecting. You may also find ways to help families navigate the educational and care system. So helping them understand better what are the resources out in the community and how to link with them. Another area that families have discussed is finding ways to increase access to information. So just as was shared earlier in the chat, you know, being able to provide high quality interpreter services in a family's preferred language. You know, we don't always have that luxury, but when we can, I think it's so important to meet families where they are in a language that they're comfortable to make sure that they're understanding the information that we want to share with them. Similarly, being able to provide a translation of written materials. Sometimes we're limited in our institutions, you know, maybe being able to only provide a one-page translation of the written report, but that might, you know, call us to take on the role of an advocate with our institutional systems to really ask for the ability to provide a fully translated report for a family, or talking with a family if they don't know how to read, to make sure, how can I share this information in a way that's going to be helpful for you. I'm going to the next slide. Other ways that we could consider recommendations that can be tailored for different cultural groups is to think about maybe multi-level education and community supports about developmental disabilities. So we may be able to find general education opportunities to give to the AAPI community about autism, about developmental disabilities, to help the community better understand what it is and what it isn't, and help dispel some of the myths that may be in the community. So it could be creating collaborations with primary care colleagues who see these families for well visits on a regular basis. But other opportunities could be parent groups for shared connections. Jasper has shared with us about the U-Lead group that she helps to do with families. So you learning empowerment after diagnosis. And these are groups that are really set about to help parents learn how to navigate the service system with ABA or speech therapy, helping provide parent support as they get to know each other and talk about their child and how they're helping meet the needs of their child. But it also provides opportunities to review the diagnosis, terminology, and provide a shared language about autism. A third bullet here, the next bullet here talks about comprehensive care coordination. And so it can be about taking time to explain the service system of care in autism. And so really helping families understand, again, what's involved, what are the resources that are available out there. And maybe it's about creating linkages for families to be able to access these service systems. So maybe your institution has a clinic social worker or a care coordinator that you can invite into the feedback session, who can then be a warm handoff to continue working with families and help making sure that those linkages are happening in a timely fashion. Another way that we can provide maybe more comprehensive coordination of care is to just model that self-advocacy skills with families who aren't as comfortable. So maybe working with them to make that phone call to the school, or linking with other providers in the community. Going on to our next slide. Thinking back to Amir and his family and some of the things that they faced, addressing language barriers. Language barriers were part of what separated the school's work from the family's understanding of what was involved in his care. And so being able to, again, provide that linkage either through care coordination or access to interpreters, so that family can become more of a collaborator with other care providers. And then also taking the time to listen to what Amir's family understands about the diagnosis of autism. We want to be able to validate the family's fears. They had talked earlier about how they were worried that the lack of exposure to their home culture had resulted in his social communication weaknesses. And so it may be validating some of those fears, and to say, I think exposure to family is going to be a wonderful opportunity, but he may still need some therapeutic supports to help him continue to develop. And so I think when you provide that education in a way that validates those family fears, you avoid the potential pitfall of maybe families holding off on tying into early intervention services because they want to take their child to their home culture in the hopes that it will fix the concerns that have been identified. And then, as we mentioned before, helping to link Amir's family to parenting education groups about autism to help them, again, flesh out a little bit more deeply about what does autism mean, what are the terms that we're using, what are the things that we're looking for to measure treatment growth in Amir's development, as well as providing them a network of support. If we go to the next slide, I'm going to transition back to Jasper, who's going to close us out and with some concluding thoughts.
Thank you, Camille, for going over those treatment recommendations. Okay, so to start out with our potential barriers, so in addition to the ones that we had identified in the chat based on audience participation and some of the things that we had discussed, I think the greatest one is limited time, right? Throughout our entire presentation, you might have noted all of the times that we said take the time to do X, take the time to do Y. And a lot of this work does take a lot of time and effort, right? Doing the research before the intake, taking time with an interpreter, providing additional services. And so this certainly is a barrier in many of our institutions. There's also often a lack of wraparound services. So once you give a family a report and outline all of those recommendations, it can be really challenging to send them out into the world and into the community to figure out how to navigate, all of these services and supports. There's also access to care issues. And so on the clinical side of things, there is a limited number of providers, which also impacts our ability to follow up with families regularly and to ensure that the child is maintaining progress in all of these recommendations that we've suggested. On the family side of things, there might be challenges with their immigration status as well as insurance concerns, just like with the Mears family in our case study. Many of us are also aware that we have very, very long wait lists right now. And so it can be very disheartening and such a barrier for families to persist with seeking an evaluation when they know that sometimes it's months and up to a year long in order to obtain an evaluation. And lastly, as many of us have discussed here through the chat and through our talk, health literacy is a big barrier here. So there's limited information and services that are provided in that family's preferred language. And so that certainly impedes the ability to get care and to receive ongoing services. Some final considerations that we'd like to put forth. Firstly, we want to encourage everyone to adhere to that multicultural and ethno-relative framework. So understanding culture and context, right? Autism is a disability that's characterized by deficits in social communication and interaction, and that is all relative. And so we want to understand where those differences and delays might lie. We also encourage everyone to maintain cultural compatibility. We know that this is aspirational, right? It's not an end game or an end goal that we can achieve, but this is something that we want to encourage everyone to continue to do and to invest in doing the work ongoing. We also want to commit to creating a cultural conversation as an integrated part of our assessment and treatment process. It's really partnering with our families so that way they feel heard and feel understood throughout this entire process, right? We're going to utilize silence as a way to integrate their cultural understanding as well as our conceptualization of what's going on with the family and the child. And lastly, we have some recommendations for improving our system of care. And so we really want to do our part into supporting communication with our families, maintaining that cultural sensitivity, as well as doing what we can to program care coordination with our families. All right, okay, here are some references. This will be posted on our slides on our website. And here we'd like to take the time to thank our audience for their time and participation and our panel for being here today. We'd also like to now open things up for our Q&A. And so I encourage everyone to go ahead and type those questions into the Q&A feature.
All right, well, thank you so much to our panelists for that really interesting and informative discussion, and really want to encourage our audience to send their questions to the Q&A feature of the Zoom toolbar. We do have a couple questions. So for our panelists, this came in early in your talk, and I think you addressed it a little bit halfway through there, but the question was, do these communities have autism in their vocabulary? So you mentioned, for example, and there's no word for autism in the Somali language, for example. So I'm wondering if there are other AAPI groups that we also should be aware of, where this could actually be an issue, that it's not in the vocabulary or terminology doesn't exist. And whoever would like to answer is more than welcome to.
Sure. I mean, I can start us off. We know that in different cultures, there is there might be a more stronger Western influence. And so oftentimes the term is autism, and they might be more familiar with that. But in other languages, sometimes the translation is like a version of like a self disorder of turning into self, or some sort of self condition. So we know that that is kind of the running theme in like Eastern Asian languages like Korean and Japanese and Chinese languages. But in other kind of more broadly, I think we want to do our part to making sure that we're having that shared term, right? So we always want to have that operational definition, defining terms, and so that way the family knows what we're talking about before we even get started. But I want to make sure that my colleagues also get a chance to shed some light on that too.
I was just going to add that it just as we were discussing through this whole presentation, I think the key really is to just slow down the process and to take feedback, right? Even the nonverbal communication, I think sometimes it gives us a sense of what the family doesn't seem to be understanding, or they look afraid, or they look anxious, and to pause and ask the interpreter, can you explain to me how that was interpreted for the family, so we can understand what they're hearing as well. I mean, I think sometimes interpreters feel stuck because they don't have a word to use when communicating it to the family. So I think just slowing down and collaborating that care with that interpreter is really important.
Yeah. And also, I mean, I really appreciated the examples that you gave. I think everyone did. And eye contact being one of the examples that you use, that in certain AAPI communities, making eye contact wouldn't be so appropriate. So what does that mean? And so really slowing things down, it's very good advice. You're right. And also I think being open, it sounds like, to asking questions and really understanding the cultural perspective and context of the people you're working with. Thank you for that. So another kind of comment that came up in the Q&A is this person said in their experience, well, they don't have a lot of, and their expertise isn't in patient care, but more in research, but they were saying they need to maybe research a little bit more, but they heard that in Korean culture, for example, that people with mental health conditions are seen as being a burden to society. And this, I think, sort of reminds me of what you were talking about in certain AAPI groups, that, this low help seeking rates and behavior is often related to shame and to stigma. And so I'm going to take that statement and maybe turn it into a question. It's a tough question, though, I think. I'm not sure how you're going to answer this, but do you have any suggestions about how to overcome some of that shame and stigma regarding accessing psychological services for the AAPI community?
I think that's such a good question and such an important one that I think, we grapple with, in trying to figure out how do we start to break down some of these barriers, because the shame and stigma is there. And it can be hard to overcome. I think some of the efforts that are being done in terms of creating community conversations, creating education, I think there are a lot of myths and misunderstanding about the source of mental illness. So within the Korean culture, sometimes families have said that they prefer to have it blamed on poor parenting rather than it becoming an autism diagnosis, right? And so then the assumption is, oh, you were a poor mother or poor father, right? And that carries its own shame and stigma inside of that as well. And so I think being able to have some conversations to normalize some of these behaviors and to reassure families that there are ways that we can treat and help families and give them hope, that it's not just a despairing diagnosis that is a forever shunning of your community, but there are people who can help. There are ways that we can make positive change. And I think if we can get that message out into the community, that can help break down some of the stigma and shame. But it'll take time because some of these are pretty entrenched.
I would also add community outreach. Us as clinicians and providers to go out into the communities and provide psychoeducation, going to areas where they feel safe and comfortable, like the mosques or temples, and providing education or attending their fairs and helping them understand what autism means, and normalizing it, right? So that they feel comfortable within their community to connect with each other and have discussions about developmental disabilities and autism as well.
I agree. I think, I've just been so struck by those infographics that were presented in the background slides that Camille had gone over, particularly that for the AAPI community, the population skews very young, right? And so maybe we want to invest a lot of time and effort in educating the Gen Z community because they're really going to be the future parents, the future family members, and the ones that are also the researchers and clinicians. And so maybe that's an area that I can think of as a researcher and a clinician that maybe I want to prioritize in terms of educating and really turning that stigma on its head.
Yeah. Well, I mean, in terms of moving the needle, I mean, discussions like this really, I think, can help to inform people. And I want to thank you all so much for your willingness to share with our group. It was so interesting, so illuminating. And there's a lot of questions that are going to be outstanding. I'm sure people will be reaching out to you, but I want to be respectful of your time as well. I also want to remind all of our viewers that we do have an evaluation that we'd love for you to complete. It's the link is in the chat. We'd love to hear more about topics that you're interested in for the next lecture series. But I think this was a great way to round out this academic year. Thank you so much again to our very distinguished panel. And we look forward to seeing you all again in the fall for the next academic year's Distinguished Lecture Series. Thank you so much to Dr. Jasper Estebia for organizing this panel and for our lecture series over this last year. And thank you to our distinguished panelists. Have a good day, everyone.
Thank you, everyone. Thank you.
Thank you.